Assalamu alaikum. So it's already after 1:10, so we can start, isn't it?
يلا بسم الله.
Good afternoon, everyone. So I have no disclosure for this presentation. I know everyone from the audience aware about the definition of non-STEMI. Just for the completion of the presentation, we'll show these slides as the definition of myocardial infarction. Usually, it's defined by the presence of myocardial injury and evidence of ischemia. And myocardial injury, it's evident by increase of the troponin more than 99th percentile of upper normal limit. In addition to the evidence of ischemia, which is evident by the patient symptoms, ECG changes, any ECG changes without ST elevation, persistent ST elevation. So it could be ST depression, TO inversion. A group of patients, actually, sometimes it's reaching about fifth of patients with non-STEMI or myocardial infarction in general might present with normal ECG. Or in addition to that, also presence of wall motion abnormality. We know that since the emerging of the high sensitivity troponin, diagnosis of acute myocardial infarction actually increased compared to the era of standard troponin, and in the same time, unstable angina actually decreased. So we have a patient with non-STEMI. We diagnosed that because of a high troponin and other findings of the patient's symptoms, ECG changes, or echo findings. Does the peak of troponin has any prognostic value? In addition to the diagnostic value, the answer is yes. And to some extent, it has a value in non-vascularized group, because a subgroup study from tracer study, it showed that a peak troponin ratio, which is the peak troponin divided by the upper normal limit troponin, that it's correlate actually with poor prognosis and all-cause mortality in non-revascularized group. But when they looked for a vascularized group, there was actually no difference. So the peak troponin, it might has a value, a prognostic value in non-revascularized group. What about beta-natriuretic? In this study, it showed that the presence of BNP at time of non-STEMI or in acute coronary syndrome more than 80 picogram per ml associated with a higher rate or incidence of death, congestive heart failure, MI at 30 days and also at 10 months. Another study also looked for BNP, and they found that BNP of 100 picogram per ml or more associated with death, myocardial infarction, or stroke with a significant p-value. What about the guidelines? Does the guidelines advise to use those biomarker to judge about the prognosis of the patients present with non-STEMI? Yes. In 2020, European Society of Cardiology guidelines of patients present with acute coronary syndrome without persistent ST elevation, they give class 1 recommendation to use high sensitivity troponin for estimation of prognosis beyond its diagnostic value. It gives class 2A for BNP to gain prognostic information, but all other biomarker, they give it a class 3. So none of other biomarker, including C-reactive protein. Is there a score model to be used to assess the risk of patients present with non-STEMI or unstable angina in addition to those biomarker? Yeah, we have the TIMI score, which is driven from a TIMI 11B trial, which consists of 7 parameters. including age more than 65, presence of risk factor 3 or more risk factors, known coronary anatomy before with more than 50% stenosis, ST deviation, 2 episodes of anginal symptoms in the last 24 hours, using of aspirin in the last 7 days, or elevated biomarker, and with the higher number of presence of variable, it's associated with the higher incidence of death, MI, or need for urgent revascularization. And actually, it's very easy to calculate because each variable will take 1 point. There is also a GRACE score, which is driven from the GRACE registry. It's a huge registry over 10 years, was conducted in 30 countries, more than 200 hospitals, more than 100,000 patients. It consists of multiple variables, but it's slightly complicated than the NSTEMI score, because each variable, it has multiple points and different points actually, but that is include basically of CRIB class, systolic blood pressure, heart rate, age of the patient, creatinine level, if the patient had cardiac arrest, ST deviation, or elevated cardiac marker. But actually the online calculator, or also the application in the smartphone, make it easy. Just you can put variables, and then it will give you directly the score. Does those score help us or make any difference in the long-term outcome? Actually, the GRACE score assessed in the AGRESS trial, they actually randomize patients with acute coronary syndrome either to standard of care or calculating of a GRACE risk score. And they found they actually develop a mean performance score, which is total of 3, including doing of angiogram before discharge, referral of patients to rehabilitation, or using of at least 4 medication out of 5, which is include the usual medication we are using for non-STEMI, which is aspirin, B2Y12, statin, beta blocker, and ACE or ARB. And they found actually there was no difference between standard of care or a GRACE risk score group. But still, in the guidelines, they recommend to use a GRACE risk score to assess the or for risk stratification, and they give it class 2A. This is depend on 2020 European Society of Cardiology guideline. So this is patients diagnosed with non-STEMI. We did risk stratification. Then what's the management? All of us, we know that the aspirin is the most important medication we are giving for non-STEMI patients. And this is since the ISIS-2 trial. And this trial, they randomized patients with acute myocardial infarction into aspirin alone, streptokinase alone, placebo, or streptokinase plus aspirin. And the aspirin was actually almost similar to the streptokinase. So since then we have evidence actually for the benefits of aspirin for acute coronary syndrome patients. What about the B2Y12? We have clopidogrel, prasugrel, ticagrelor, and now the IV cangrelor with a different bioavailability, the different onsets and half-life. But what about the evidence behind that and clinical outcome? Clopidogrel assessed actually a long time ago, more than 20 years, by a CURE trial, which is randomized patients with acute myocardial infarction into clopidogrel loading dose to 375 milligram or to placebo. And they looked for primary endpoint of cardiovascular death, myocardial infarction, or stroke. And they found that the clopidogrel group associated with the lower primary endpoint with significant p-value compared to placebo, but unfortunately with slightly higher risk of major bleeding. Triton-TIMI 38 study, it looked for, they compared the clopidogrel to prasugrel. They randomized patients with STEMI or non-STEMI and planned for PCI, either to clopidogrel 300 or prasugrel 600 and then 10 milligram, with median duration of follow-up of 12 months, primary endpoint of cardiovascular death, MI, or stroke, and safety point of TIMI, major bleeding, life-threatening bleeding. And they found that prasugrel associated with the lower incidence of primary endpoint, but unfortunately also with a higher incidence of bleeding compared to clopidogrel. They assessed also the visibility of loading the patients with prasugrel after angiogram. So they compared of pre-treatment with prasugrel to treatment or loading in the cath lab. So the randomized patients with non-STEMI into either pre-treatment with prasugrel before angiogram, 30 milligram, or with placebo loading. Then they did angiogram, and then they decide either the patient will go for medical therapy or CABG, or to PCI. Those going for PCI, and they receive already a prasugrel pre-treatment, they load more with more 30 milligram just to complete the 60 milligram. Those receive only placebo before the angiogram, they load with full dose of loading dose of 60 milligram. And they looked for cardiovascular death, MI, stroke, using of glycoprotein to be 3A bail out at 7 days. And they found that either pre-treated or not pre-treated with prasugrel, actually there was no difference in the primary endpoint, but there was higher bleeding in the pre-treatment group. And from this study, the guidelines actually recommend not to pre-treat patients with prasugrel. If you are planning to use prasugrel, to load the patients after the angiogram if you are planning PCI. Then from Plateau trial, which is randomized patients with non-STEMI or STEMI into either clopidogrel or ticagrelor, they looked for primary endpoint of cardiovascular death, MI, or stroke at 6 to 12 months, and primary safety points of total major bleeding. They found that the ticagrelor associated with the lower risk of stent thrombosis, MI, or death, without actually difference in the major bleeding. So now we know that clopidogrel better than placebo. Prasugrel is better than clopidogrel in the reduction of primary endpoint, but with a higher risk of bleeding. Ticagrelor is better than clopidogrel, but with without actually risk of increased risk of bleeding. The comparison of the ticagrelor to prasugrel, it's done in the ICER REACT trial, and they found that the prasugrel actually associated with the lower incidence of primary endpoint. What does the guidelines recommend? They recommend that P2Y12 for the patients either naive or previously treated with P2Y12 to receive prasugrel 60 milligram as loading and 10 milligram as chronic use after that, or 5 milligram, depending on the age and weight of the patient, as class 1. Ticagrelor, and this is only for the patients planned for invasive, so proceeding for PCI. Patient either for planned for invasive or non-invasive can receive ticagrelor as the P2Y12 with loading 180 and then 90 milligram BID. Clopidogrel, 300 to 600 loading and then 75 milligram daily, only if prasugrel or ticagrelor not available or cannot be used or contraindicated. They give prasugrel over ticagrelor class 2A. So if the patient is proceeding for PCI. So patients in ER with non-STEMI should receive P2Y12. Better to receive ticagrelor over clopidogrel if it's available. If the patients you are planning to use prasugrel, don't load with the patient with prasugrel. Wait for the angio. Then after angio, if the patient is for PCI, can be loaded with prasugrel, and according to European Society of Cardiology, it's preferred over ticagrelor if there is no contraindication. Anticoagulation, we know from TIMI 11B, they randomized patients into unfractionated heparin or enoxaparin, and they looked for a primary endpoint of death MI or need for urgent revascularization, safety of major bleeding, and they found that the enoxaparin associated with the lower incidence of primary endpoint with early benefit actually at 48 hours, and the curve continued to divert in the long-term follow-up, and enoxaparin associated with the lower incidence of bleeding. This observation also seen in the ESSENCE study, which showed that the enoxaparin has a lower rate of primary endpoint compared to unfractionated heparin. So right now, we know that the patient should receive aspirin, should receive P2Y12. Ticagrelor is preferred over clopidogrel, and prasugrel preferred over the ticagrelor and clopidogrel. If the patient already, we know the anatomy in the angio and proceeding for PCI. All patients should receive anticoagulant, and we prefer enoxaparin if there is no contraindication. Otherwise, you can use IV heparin. Then what about the supportive therapy, which the most important is revascularization? The time of revascularization, it's depend on the patient risk. They divide the patients into low risk, high risk, or very high risk. And very high risk patients, if there is hemodynamic instability, cardiogenic shock, recurrent or refractory chest pain, regardless the medical therapy, life-threatening arrhythmia, acute heart failure related to non-STEMI, or ST depression more than 1 millimeter in 6 leads with ST elevation in AVR or V1. European Society of Cardiology 2020 guidelines recommend those patients to go for immediate invasive, just similar to STEMI patients, and they recommend to go for invasive less than 2 hours. Early, actually, in the last recommendation, they give early invasive for those with dynamic new or presumably new two contiguous lead ST deviation with or without symptoms. Resuscitated patient if he is stable after that with or without ST deviation, or GRACE score more than 140, and they recommend that to go for early invasive. The low risk, it's actually selective angio. But from where they get the recommendation regarding the early invasive, from multiple actually trials, and the most important 2 trials, it's Verdict and TIM-ACT trial, which is more than 2,000 patients in Verdict and more than 3,000 on TIM-ACT trial. But unfortunately, those all trials actually, the problem with those trials, the early invasive, it's actually calculated from the time of randomization. It's not from the starting of the chest pain and not from the hospitalization of the patients. with actually also variable timing of the intervention or invasive in the late group. But from those large trials, there was actually no difference in the composite endpoints between the early and late invasive strategy. What about statin in acute coronary syndrome or in a non-STEMI? We know that from the Miracle study, which is an old study in 2001 published, and they randomized patient into atorvastatin or placebo, and they found that the atorvastatin associated with the lower incidence of death, non-fatal myocardial infarction, cardiac arrest, or worsening of angina. And that benefit actually shown early in the study at about 1 month. Then the PROVIT, they looked for the benefit of high-intensity statin compared to moderate intensity. They randomized patients into atorvastatin 80 or pravastatin 40 milligram, and they found that the atorvastatin associated with the lower rate of death, MI, or rehospitalization for acute coronary syndrome. And the benefit actually was early in the randomization as about less than a week, and it's continue actually the curve continue for divergent in the long term follow-up. What about beta blocker in the patients admitted with non-STEMI? And here I'm talking about non-STEMI without reduction in ejection fraction, normal ejection fraction. We know that those patients with reduced ejection fraction, for sure, they get a benefit from beta blocker. But regarding beta blocker, in those with non-STEMI and normal ejection fraction, the short answer, we don't have data. But there is actually ongoing 4 trials, which is REPOT, Beta MI study, Reduce Sweden Heart, and DAM block trial. Still, we are waiting for the result from those trial, and it will tell us about using of beta blocker in those patients if will have a benefit to discharge those patients on beta blocker or not. What about also renin-angiotensin system inhibitor with patients with stable coronary artery disease without heart failure? So those patients with non-STEMI, should we discharge those on ACE or ARB or not if they have a normal ejection fraction and you are not using this medication for control of blood pressure? Actually, from systematic review and meta-analysis, it showed that there was no benefit. I didn't spoke about spironolactone or eplerenone because also those studied actually for those with reduced ejection fraction less than 40% with symptoms of heart failure or in diabetic patients, those got benefit, but more than 40%, no study. PPI, it's recommended for patients on dual antiplatelet and at higher than average of GI bleeding. That means the patients with history of gastric ulcer, hemorrhage, those on anticoagulants with dual antiplatelets, those using of chronic non-steroidal anti-inflammatory drug or corticosteroids, or those with 2 or more of the following risk factor, which is the age more than 65 or more, dyspepsia, GERD, Helicobacter pylori infection, or chronic alcohol use. So those patients should be on PPI just for safety. you should, and all of my recommendation I mentioned, actually, it's for a type 1 myocardial infarction non-STEMI. I didn't spoke, this recommendation, it's not regard for the patients with type 2, which is the demand ischemia. It's not for the type 3, not for type 4 or type 5, which is PCI related or CABG related. So it's mainly for a type 1 MI, which is the MI, which is associated with the plaque disruption. For patients with non-STEMI, before discharge, you have to advise patients for physical activity, and the recommendation for 30 to 60 minutes of moderate intensity aerobic activity at least 5 times a week, and to be started gradually for those patients post myocardial infarction. A multidisciplinary cardiac rehabilitation, it's consistently demonstrate its effectiveness in reducing cardiovascular mortality and hospitalization compared to no exercise. Patients with heart disease has twofold increased risk for mood disorder and anxiety compared to general population. So those patients, actually, you have to assess them for this issue and refer them to psychiatrist if they need. Regarding sexual activity before, after myocardial infarction, it should be resumed safely after 2 to 4 weeks after non-STEMI. And by the studies, the sexual activity actually, or the intercourse actually, is required about 4 to 5 minutes, which is almost equivalent to going to 1 flight upstairs. So it should be safe after non-STEMI if the patient is comfortable and he can go this level of efforts without any symptoms. You have to refer the patient for smoking cessation if he is a smoker. This is a very important actually step to be initiated before discharge. Annual influenza vaccination is recommended for all patients with chronic coronary syndrome. So those patients at the time of discharge, you have to document in their chart that they have to get the annual influenza vaccine. What about driving after non-STEMI? There is actually a recommendation from European Society of Cardiology, which give a private driver, he can drive after 1 month after discharge. Those with commercial driver's license, 6 weeks after discharge. There is a bit of details according to the Canadian Cardiovascular Society in this regard. They divide those patients with non-STEMI into low ejection fraction or normal ejection fraction. Those with normal ejection fraction and the private driver, they can drive 1 month after discharge. The commercial drivers, 3 months after discharge. With normal ejection fraction, they divide them also with private driver or commercial drivers. Those with private driver, the private drivers, and underwent PCI with complete revascularization, they can drive after 48 hours. If there is no PCI done, so after 1 week. Commercial drivers, PCI done, they can drive after 7 days, no PCI after 1 month. So a bit of details in the Canadian. Thank you very much for your listening. And just I tried to make it very concise and short and to open it for discussion. Any question? So here in the chat, I have P2Y12 to pre-treat or not prior to PCI. So in non-STEMI, actually, there was no difference. For example, if we compare the prasugrel to prasugrel pre-treatment or not to pre-treat, so we can take that most likely there is no difference between pre-treatment and or not to pre-treat. But I prefer, if you are not planning to use prasugrel, to pre-treat all patients, just because we don't know if this patient will go for angio soon or not. So everyone better to be treated with P2Y12, either ticagrelor or clopidogrel. But according to the guidelines, ticagrelor is preferred over clopidogrel. Hopefully this is clearly answer your question. Then from Hassan Ali, if coronary angio planned in 24 hours, should we wait for the treatment with prasugrel? If you have prasugrel available in the hospital, yes, you can wait. And just after angio, you can decide either to load if you are going for PCI or not. And this is according to the guidelines. Okay, then regarding ACE and STEMI without reduced ejection fraction or diabetes. So if there is no, the ejection fraction is normal and blood pressure is normal, you are not planning to use it just to control the blood pressure. So there is no evidence. Systematic review showed no benefit. Any specific recommendation for duration of anticoagulation? So for all acute coronary syndrome, it's recommended for 12 months, regardless the strategy, either invasive or non-invasive, even those without PCI. So recommendation for 12 months if you are using the dual antiplatelets. If the patient on anticoagulation and you are using the dual antiplatelets with that, recommendation to take it from 1 week to 1 month, the dual antiplatelets with anticoagulant. Then to drop one of the antiplatelets, usually recommend to drop the aspirin and continue the clopidogrel with the anticoagulation for a total of 12 months. Then you can stop the P2Y12, which is usually the clopidogrel, and continue just the anticoagulation if you are using the anticoagulant for other indication, for example, atrial fibrillation. What about flying post non-STEMI? The flying actually depends also on the revascularization. If the patient's completely revascularized, he can fly after PCI, after discharge, without any problem.
Dr. Muqla,
yeah.
I think he meant anticoagulation in ischemia-guided non-STEMI or delayed invasive. For example, patient admitted and you will do a PCI after 3 days, and you plan to give him heparin or enoxaparin. So
okay.
is it 48 hours or till PCI or 8 days?
Okay, so for the anticoagulation before PCI, if we are using heparin, the recommendation is for 48 hours. And enoxaparin, actually, if the patient, we didn't actually do intervention, he's not for the invasive strategy, we can use it for up to 8 days or until the patient for discharge. If the patient revascularized, so stop all anticoagulation post-revascularization, either heparin or enoxaparin. Is it clear? Dr. Ibrahim?
Yes, very clear.
Okay, so we'll continue the chat because actually many questions, so I'm in a hurry just to answer all of them. What about, Okay, loading dose of heparin or enoxaparin. So for those non-STEMI, just we can go with enoxaparin as shown in the studies, in the TEMI Triton, and in the other studies that enoxaparin better than heparin, unless there is contraindication, for example, renal impairment. If for patients with STEMI, we prefer usually heparin, but because the patient will go for revascularization or for cath lab immediately. Also, we have actually a study which is called ATOL trial, which showed even safety of using enoxaparin for those going for early revascularization, either STEMI or non-STEMI. You can even give in the cath lab enoxaparin IV, which is safe. But for non-STEMI, we prefer just to treat the patient with enoxaparin. Enoxaparin heparin duration in medically treated non-STEMI, we answer that, which is the either 48 hours for heparin or enoxaparin total of 8 days or until the patient discharge. Any prognostic value for serial troponin after diagnosis of non-STEMI for revascularization patient? No. From the study subgroup analysis, it showed that for those underwent revascularization, there was no value actually for looking for the peak troponin. If the patient received loading dose of clopidogrel, okay, post-PCI decision was to change to ticagrelor. Should we load with ticagrelor or just start daily dose? No, you have to load with ticagrelor. And for escalation from clopidogrel to ticagrelor, just you can load at any time. And it showed that forget the name of the study, but it was recent, I think in 2019 or 20. It was actually safe to load the patients with ticagrelor, even those receive thrombolytic. So yeah, for those pre-treated with clopidogrel, even with loading dose, if you are escalating to ticagrelor, you have to load. And you can load right away at any time, which is different slightly from de-escalation. If you are de-escalation from ticagrelor to clopidogrel, you have to wait for 24 hours to load with clopidogrel. What about revascularization for multivessel in patients with non-STEMI? So complete revascularization is recommended, but it's not in the same index procedure. You can revascularize the patients after that, either in the same admission or after this charge, and bring the patient within 21 days. For the patients with cardiogenic shock and multivessel disease, revascularization of non-culprit lesion, actually it's class 3. So because of harm. So it shouldn't be done in the same setting for those with cardiogenic shock. Okay. So this is the last question actually in the
doctor, excuse me, doctor.
Yep.
Yes, but how can I know the exact culprit in case of non-STEMI? You know that the correlation is not 100% in patient of non-STEMI.
Agree.
So
100%.
Yeah.
So sometime actually you will have some evidence by the angio. You will see that there is evidence of thrombus. There is an evidence of plaque rupture. Sometime it will be difficult. You're right. Because you will have just a tight lesion in all 3 vessels, for example, and you don't know which one is culprit. It might be helpful to use intravascular imaging, either IVUS or OCT, optical coherent tomography, to assess those lesions and to know which one is the culprit. But sometime even with that, it will be difficult. But many patients, you will be able to judge which one is the culprit. I'm not sure there is class 3 recommendation. I'm not sure what do you mean. The recommendation level. The class 3 recommendation, that means it shouldn't be done. I mean the revascularization for patients in cardiogenic shock, non-STEMI, multifaceted PCI, or PCI of non-culprit lesion shouldn't be done in the same setting. I think it's better to go for actually just to open your mic and ask the question. We can actually discuss the question better if you have any question.
Doctor, thank you for your lecture. I have a question regarding the revascularization of non-culprit vessels. So the recommendation is very clear for the STEMI patients that we should do a staged BCI, unless if it's a very, I mean, a non-complex, non-culprit lesion, and there are no complications. We can do it in the same setting. So is it the same? It will be the same for non-STEMI as the STEMI? The same recommendations will be applied?
The recommendation right now in the guidelines, actually, the only recommendation is for revascularization of non-culprit in cardiogenic shock, which is class 3. Others, actually, no clear recommendation, but we can use those for STEMI, which is just you can stage it in another setting, unless, as you mentioned, that it's simple lesion, you can do it without any much of extra contrast or prolonging of the procedure.
So I can now, for now, we can apply the same recommendations for STEMI on non-STEMI patients also.
Because we don't have a clear actually for those non-STEMI.
Yes, exactly. Thank you so much.
So is there any trials for pre versus post PCI format using clopidogrel or ticagrelor, or we should load upon admission using these agents? So for ticagrelor, we have actually, and it showed that there is no difference between pre-treatment. There was no difference. So you can just wait until for post angio. If the patient is going for early, actually, I recommend not to load because many of cardiac surgeons, for example, they will delay the procedure. If the patient is for CABG, they will delay the CABG because the loading of P2Y12. So if the patient is going early for angio in the same day, I prefer not to load, just to wait for the angio, and then you can load the patient on the table. For clopidogrel, because the onset of the action is slightly actually slow, if you have only this medication in your hospital, I prefer myself to load the patients on admission with 600. If you have ticagrelor in your hospital or prasugrel, just wait for the angio, especially if you are going for the angio soon after admission. Any more questions?
الله يعطيك العافية دكتور مقنع، شكرا جزيلا، ما قصرت.
لا، الله يعطيكم العافية. شكرا، موفقين.
الله يعطيك العافية دكتور، شكرا جزيلا.
الله يعافيك، شكرا.